stake exam, like exit exam of the FCPS Part 2. When we remember then when we were graduating, most of us who were graduating from medical college, they used to give us a long case, जाओ उसकी history ले लो, फिर वो एक examiner कुछ अरसे बाद कुछ time पे आ जाता था, जी आपका क्या case है, and then he used to ask some theoretical question. So that examination was not observed, and almost the theoretical aspects were discussed. It was more subjective, non-reliable, and carried highest bias. So the problem occurred when the demise of the traditional long case occurred in 2005, when Royal Colleges discontinued traditional long cases. And they introduced the new variations of the long cases, keeping the long cases by newbie in 1996, and it was observed long case, and this is basically the main what CPSP format is also doing in the long case. Then Gleason started in 2000 objective structured long examination, Osler, which is very much popular now in the UK and Scandinavian countries, and structured clinical case examination. This is from India, Pandya, so very good thing. So the research gap was basically, in the literature, I found that it was not apple-to-apple comparison. Majority, 99% of the literature was comparing a traditional long case, which was not observed, with the Osler and saying Osler is very good, Osler is very good, Osler is very good. That was not an apple-to-apple comparison. So then we started into doing this work to start with. So the hypothesis was the Osler and SCC are effective, reliable, and acceptable assessment tool compared to the observed long case, which is called as also we call as CPSP format. So this is basically the research gap. And the objective to compare the effectiveness, inter-rater reliability and acceptability of the Osler, SCC in observed long case in assessment of the clinical competency of postgraduate residents in urology. This was some operational definition, what we meant by effectiveness, what was the clinical competency. ये वही चीजें जो आपसे long case में पूछी जाती है. History, examination, investigation, clinical acumen, acceptability कितनी है, सबसे बड़ी बात है कि कितना ये format कितना acceptable होगा. And the strength of the study that it was a mixed method study, we also checked the acceptability. It was conducted in our department because we very frequently do these assessment examinations, and also by the IHPR, which is a KMU, Health Profession Education Department. We had, because we have almost 80 residents in our center. So we selected 60 residents and 10 supervisors. Sampling was simple, random, and for the quantitative and purposive sampling for the qualitative. But we did that the 30 students each for the second and third year student, each with higher and lower scoring with my resident, and especially when we did usually we do annually. पूरे पाकिस्तान से हमारे पास residents आते हैं, annual हम एक course कराते हैं, final fellowship pre-exam assessment. तो उसमें 60-70 residents पूरे पाकिस्तान से आते हैं, जिसमें हम लोग उनके साथ पूरा theory, long case, short case, talks, extended talks, everything we included there as a FCPS examination. Data was collected in on the three. These were the performers on which data was collected. This is the modified Osler performer. Modified Osler performer of the IKD, which I made it because I have put it a very component score in the system, and all is the agreed answer. This is the SCC, and ये जो है ये CPSP का है. This is the CPSP format, the observed long case. Then we conducted interviews. Interviews हम ले रहे थे, and then we conducted the interviews, and that was according to the theoretical framework of the interview guide. And ये Osler था, ये SCC था, ये CPSP फॉर्मेट वगैरह पे हम लोगों ने रेजिडेंट्स को असेस किया. अब ये जो क्वालिटेटिव स्टडी का रिजल्ट्स आए, दैट शोड कि इट वाज डेटा वाज नॉर्मली डिस्ट्रीब्यूटेड, क्योंकि पीछे तीन क्वेश्चनर्स थे क्वांटिटेटिव पोर्शन में. Majority, as you know, that urology is a male-dominated, specialty. So majority was male, and in the selection of cases, we selected standard and difficult cases in the long case examination. We didn't very simple cases because keeping the objectivity for the postgraduate, the urology that will be appearing in the exam. So we didn't put the simple cases, it was standard difficult one. Now this is important that for the oscillator, this is the, statistically speaking, this is the basically Cronbach alpha that shows the reliability. That is a highly reliable and valid. 0.98 that can be generalized in the population. This was the SCCE, which was also good. The other format, but this was the problem with the CPSP because the inter-rater reliability was not at the par. One examiner was scoring like this, and the other examiner was scoring like this. Even having the agreed answer key, because of some, I will be discussing it thoroughly with the Professor Nasir, who is our dean, that how to work on the component scoring system. Because the problem with that, even if you keep this observed long case, we have to work on the component scores for the residents to help the residents. This is again the pass-fail percentage. You can see that there is a gross variation in the CPSP module. This is the kappa value that also shows that internal validity was very good for the, and this was like the thematic analysis, like in the mixed method study, Braun and Clark method, in which you take an interview and then subscribe it and transcribe it, and then you do the analysis. So these were the words which were, and this was taken from the teachers as well as from the residents, and after 9 interviews, the data saturated. These were the frequently ordered words which were, in the interview which was recorded. And these are the themes which we found from the resident as well as the teacher. Attitude towards existing modality, challenging to face long cases, nature and impact of existing modules, recommendation and their need for improvement. Positive attitude toward oscillator, I feel good. One of the residents who appeared in the exam, as it is more objectively assesses the scoring criteria, strong desire to adaptation of new modality. Express concern about the subjectivity in the CPSP format, which I've been taking. Why there is a subjectivity? Because in some component score, like in taking the history, अब आ रहा है कि उसमें 20 marks. अब 20 marks resident सिर्फ अस्सलाम वालेकुम, पंखा बंद कर दूं, पंखा ऑन कर दूं, गर्मी ज्यादा हो गई, गर्मी ठंड हो गई है. अब उसको पता नहीं है कि मुझे 20 marks किस चीज में लेने हैं. ना एग्जामिनर को पता चल रहा है कि यार उसके में किस चीज, क्योंकि the resident who has been trained, वो बिल्कुल typical एक वो stereotype के जुमले, मेरा नाम फलाना है और ये सब, and he thinks that this courtesy is going to give him 10 out of 20 marks. So this deficiency in the component score of our format was very, like nature and imperative of exactly problem is even the component score. And most of the teachers that we took, they said that SEC is good for the undergraduate exam because it mostly addresses the history and examination. But from here, we even go to the robotics and laparoscopic and recent advances in research also. Now, this is one of the example which I've recently taken my assessment on the infection module, and I make scenarios, case-based scenarios. If you say we have to do the component scoring of our format, the long case format or the TOEFL examination, which we say TOEFL examination passing percentage बहुत ज़्यादा है. TOEFL examination passing case based scenario डालो, long case खत्म करें, फलाना करें सब. जब तक हम इस पे नहीं आएंगे, but देखिए एक क्वेश्चन था, ये बेसिकली इन्फेक्शंस मॉड्यूल था और एक केस बेस्ड सिनेरियो वाज ऑन जेनिटल ट्यूबरकुलोसिस. अब उसका क्वेश्चन था व्हाट इज दिस फिनोमेना, जिसका आंसर था स्टेराइल पायूरिया. सिंपल रिकॉल है, उसने कुछ ज्यादा नहीं करना. इसके सिर्फ 0.5 मार्क्स है. What is the reason for this phenomena? Because this was it is mycobacterium grow in the LJ medium, 1 mark. So when you divide this component score, कि जहाँ resident फिर कहते हैं मैं तो सब कुछ बोला जी, blood CP, ESR, urea creatinine, LFTs, इसका component score कम रखिए, and then इसका ज़्यादा रखें. आप बिल्कुल cystoscopic biopsy, आप this IVU, CTU, urinary PCR, इसका component score ज़्यादा रखें. लेकिन अगर आप general लिख देंगे 20 marks, तो then The resident says, I have told the examiner 20 questions, but he has not scored me. So these are the things. And वहाँ का भी examiner के जहन में था कि जब तक ये CTU नहीं बोलेगा तो मैं पास नहीं करूँगा इसको. So we have to be very methodical with this assessment in this thing. The strength of the study that it was a mixed method study. We used validated tools and we studied the acceptability. Reliability of the oscillator has been established in the literature. This is the CPSP format. जो जितने भी observed long cases हैं जिनके वो component score पे broader spectrum में discussion 40 marks. और what do you mean by discussion? 40 number दे रहे हैं आपको, दो examiner बैठे हुए हैं, उनके agreed answer पे जब तक आप agree नहीं होंगे तो these problem will come. And they say they start scoring their own convention. अगर आपके पास वो आया और you have to ask him in the recent advances और examiner को सिर्फ urinary में ले बैठा तो उसको recent advances पे तो marks नहीं मिलेंगे. So this is the problem that I would like to highlight it in our assessment.
Sir, please conclude.
Yes, well, this is the last slide. So this is the effectiveness, the grading. These were some descending voices in the course and positive. So the limitation that we could not accommodate MS students because MS is not offered in the KPK. And with this, I conclude this new assessment tool of the oscillator, which is a modified oscillator of the tool, is more effective, reliable, and acceptable than SEC and observed long case of the CPSP format. And this is the last take-home message, that we cannot standardize the patient, we cannot standardize the resident, we cannot standardize teacher because we all are human. Human cannot be standardized. But we can, sir, we can standardize the training and assessment. And this is the need of the day. Thank you so much.
Question?
हमारे यहाँ पाकिस्तान में स्टैंडर्डाइज्ड ट्रेनिंग है